Well, welcome. This is Jill with Mountain Pacific, and I'd like to welcome you to our Making Molehills Out of Mountains MDS presentation today. I'm going to give just another few seconds for people to get logged in and settled in, and then we'll begin our presentation. All right. Welcome back again. I'm Jill Holt with Mountain Pacific, and it's my great pleasure to share with you the presentation today. This is a collaboration with the Wyoming Department of Health. And so I'd like to introduce the coordinator from the Wyoming Department of Health who helped make this all happen. His name is Tim Kozad. He is the lead long-term care surveyor, health surveyor for the state of Wyoming, and he's been at that post for a little over 7 years now. So Tim, I'll let you introduce our speaker. Thank you.
Thank you, Jill. It gives me great pleasure to introduce our speaker, Jessie McGill. Jessie is a curriculum development specialist and master teacher for AAPACN, the American Association of Post-Acute Care Nursing. So thank you, Jessie, and it's all yours.
Thank you, Tim, and thank you, Jill. It's such an honor to be here. And thank you all for taking some time out of what I know is your very busy day to join me and talk about MDSs and with a focus on ARDs. All right, we'll get our screens moving here. All right, so today I'm presenting on making molehills out of mountains. We have a couple learning objectives. First is to explain exactly what the assessment reference data, or ARDs, are and what impact they have on observation periods, completion dates for the different OBRA and PPS assessments. We're also going to talk about strategic approaches to ARD selection using your existing facility meetings and processes, and recognize how state and federal payment policies impact ARD management. Most everyone has heard the term or the saying, making a mountain out of a molehill. And usually when we say that, we're talking about someone making a really big deal about something that's pretty insignificant. But today we're going to look at ARD management, and ARD management really is a mountain of responsibility. It is a key role of the nurse assessment coordinator to really keep the facility assessments moving and scheduled, and making sure that we're appropriately capturing the cares and services that we're providing. So today we're going to talk about how to turn ARD management into a molehill, something that you still need to keep an eye on, but it's not something that needs to consume all of your time and be overwhelming. So we need to have a really strong process to manage ARDs and keep that process moving. All right, so we're going to start with ARD Defined. The ARD is the assessment reference date. This is MDS item A2300, and it is the endpoint in time for all items with an observation period on that particular assessment. And different MDS items and sections have different observation periods. But what they have in common is that all of those observation periods end on the same day, which is the ARD. So this establishes a common observation period for all the interdisciplinary team members that are working on the MDS, and they all know when their observation period ends based on that ARD. The ARD is also key because that observation period also determines which cares and services we're actually going to capture on the MDS. The ARD also sets the completion period for some MDSs. So we're going to talk about the different MDS assessments and which ones have an ARD that sets that completion date, and the other items which are really impacted by the ARD. The ARD must be set timely to ensure assessments are completed timely and within the state and federal compliance. Now, I want to mention this here, and I'll probably say it a couple more times because it is so important. when I talk about the OBRA assessments today, I'm really focusing on the federal regulations. Depending on your state requirements, you may have state rules around OBRA assessments that are more stringent than the federal regulations. So it's really important to apply both your state and your federal rules. However, I am not familiar with every state and their specific rules, but I will speak to the federal regulations and compliance. All right, so I love to have visuals. So really quick visual on that ARD window. So if we have an ARD that's set as of today, April 28th, and we talk about that 7-day look back period, which is really that standard look back period for most MDS items unless otherwise stated. So typically what we do is we'd have our ARD and we count back those 7 days. So as I just get those all that come up on the screen here, that's our look back period, day 1 through 7, with day 7 ending on the ARD, the last day of that look back window. So when we talk about the observation window, especially the 7-day look back window, this is that time frame. Anything that happens as of 12 a.m. on that first day of the look back period up until 11:59 p.m. on that last day, the ARD. The same concept applies when you have a longer look back or observation window. So let's look at, say, the 14-day look back period. Here we are still ending on the ARD, but as we count back 14 days. And what is similar with that concept is that both of those look back periods end on the ARD. So that's the date that sets the end of that look back or observation period. All right, so now we're going to get into OBRA assessments and ARD setting for the OBRA assessments. If you are newer to the MDS process, the RAI User's Manual has a great chart, and this is on pages 2-16 through 2-18. This is something, if you use a paper RAI manual, a good page to flag with some tags. If you use the electronic manual, print out these pages, have them available, because it really provides you in these simple charts, the ARD window, the look back periods for 7 and 14 days, the completion, if the assessment requires cause or care plan, those completion dates are on there, as well as your transmission dates and other pertinent information. So these couple pages of charts really provide key information to help keep you in compliance with the scheduling of the OBRA assessments. When we talk about OBRA assessments, there's really 3 big buckets. We have our comprehensive assessments, our non-comprehensive assessments, and then tracking records. Comprehensive assessments are assessments that require the care area assessments as well as care plan completion as part of the RAI process. And the comprehensive assessments also use a larger item set than your other assessment types. So when I say item set, what that essentially means is that is the MDS. So a comprehensive MDS has a set of items that is specific to the comprehensive item set. And when we talk about the non-comprehensive, like the quarterly, those MDSs have a subset of the items from the comprehensive, but it's actually a different item set. So when we talk about the types of assessment, we are really looking at the item sets that are included in that assessment. Our comprehensive assessments include the admission, the annual, the significant change in status assessment, which is also called just a SIG change and abbreviated as SCSA, and the significant correction to a prior comprehensive. We also have our non-comprehensive assessments. We have our quarterly assessments, a significant correction to a prior quarterly, and then our 2 OBRA discharge assessments, return not anticipated and return anticipated. And then we have our tracking records, and these are not assessments. They are records only. They are to really communicate to CMS through the MDS process that an event has occurred. So entry has occurred into the facility, or a re-entry, or a death in facility has occurred. As we go through the OBRA assessments, we are going to focus through this standard OBRA assessment cycle, which starts with a comprehensive assessment and then moves through a first, second, and third quarterly, and then followed by another comprehensive assessment. Now, we will talk about it a little bit more later, but you can have more than 3 quarterlies in a calendar year. So this is just a kind of a guideline of, on a typical calendar year, you'll likely have a comprehensive and at least 3 quarterlies during that cycle. The first assessment that we're going to talk about is your OBRA admission assessment. Now, you're also going to have an entry tracking record, but for your tracking records, that is really focused on the event. So the ARD of your entry record has to be on that entry date. So it's a very, very simple concept of the entry date equaling the ARD. So we're going to start with the admission assessment, where the ARD can be no later than your admission date plus 13 calendar days. I am sure many of you are familiar with the term, we have to have an admission assessment done by day 14. That is correct. Admission date is day 1 plus 13 additional calendar days equals day 14. We also have to have the MDS and cause done by day 14, because that is the assessment process for your comprehensive assessment. From the CA completion date, you have an additional 7 days to complete the care plan. Now, one of the common myths I hear when it comes to the admission assessment and the completion is that you have until day 21 to complete your care plan. And that's not entirely true. So where that comes from is if you complete your cause on day 14, and you have an additional 7 days to complete your care plan, that would equal day 21. However, if you complete your MDS and cause early, let's say you sign the cause complete as of day 12, now you only have 7 additional calendar days from that day 12 when you sign the cause as complete to complete your care plan, not all the way out to day 21. So that care plan completion date is directly related to the CA completion date and not a strict calendar date from the entry into the facility. All right, so let's take a look at how that admission assessment works with that standard OBRA assessment cycle. The admission assessment is a comprehensive assessment, so it fits into that bucket of comprehensive assessment. And we have to have that ARD set on day 1 through 14. Now, we also have to have the MDS completed by day 14. So even though you have the allowance to set that ARD all the way out to day 14, you also have to consider that that assessment and cause must also be completed by day 14, which would make it very difficult to complete that assessment and complete the cause by day 14. So typically we're setting it a little bit off of day 14 earlier into the stay so that we have additional time to complete the MDS and cause by day 14. The next OBRA assessment we have is the OBRA quarterly assessment, when the ARD can be no later than 92 calendar days from the previous OBRA assessment. So this is looking at that OBRA ARD and adding 92 calendar days. The quarterly MDS must also be completed within 14 days of the ARD. So this is an assessment that has a completion date that is directly related to that ARD date as well. So when we look at our standard OBRA assessment cycle and that first quarterly assessment, we're looking at a 92-day count from the previous OBRA assessment. Well, since this resident just came in, we completed the admission assessment. Right now, that's the only OBRA assessment we have completed. So from the admission assessment, we're going to count 92 calendar days from the ARD. And that day 92 is the very last day we could schedule this quarterly. You can schedule it earlier. You can schedule it on day 60, on day 77, day 82, day 90. You can schedule it really anywhere 92 or earlier, but if you are beyond day 92, then you are out of compliance with the quarterly OBRA schedule. The next quarterly is going to be due within 92 days of the previous quarterly. So the first quarterly ARD plus 92 days is the last day that you could schedule that second quarterly. Again, you could schedule it earlier. And then from the second quarterly, again, another 92 days to when that third quarterly would be due. Now, again, we're gonna mention this again, but you could have more than 3 quarterlies. But the key here is no more than 92 days between any 2 OBRA assessments. that date can be earlier, and however early you set that is also going to drive how much earlier the next assessment is going to be due, because it's not, it's always 92 days from the previous assessment. So each assessment does impact the subsequent assessment. All right, and that brings us to the annual assessment. And the annual assessment has two different rules when it comes to scheduling the ARD. The ARD can be no later than 366 calendar days from the previous comprehensive OBRA ARD, and has to be within 92 days from the previous OBRA ARD. So again, two rules. Comprehensive to comprehensive cannot exceed more than 366 calendar days, and OBRA to OBRA cannot exceed 92 calendar days. The annual also has a completion date that is really regulated by the ARD, and it's ARD plus 14 days for that completion date. All right, so here we're looking at our assessment cycle again. The annual assessment is a comprehensive assessment, so it fits into that comprehensive assessment bucket. And we again have to meet both of those rules. So the first one is 366 days from the prior comprehensive. So if we go through this example that we've been working through, the resident admitted, we had the admission assessment, and then 92 days, within 92 days, we had a first quarterly, second quarterly, third quarterly, and now we're almost a full year later. We have to look back to that admission assessment because that was our last comprehensive OBRA assessment. So now from that admission assessment, we're looking all the way around the calendar year to count out what day 366 is. And we cannot go beyond day 366. However, we also cannot have greater than 92 days between any two OBRA assessments. So from that last quarterly we have to have no more than 92 days before this annual assessment is scheduled. Now, I mentioned earlier that you might have more than 3 quarterlies, and this is really why, because if I were to say schedule my first quarterly closer to day 60, and same thing with my second and third quarterly, I'm going to have a really big gap between that third quarterly and when my annual would be due. So that's when I might have a fourth quarterly needed within that calendar year. But let's take a look at this on another visual. So here I have more on a timeline. I go from my admission, first quarterly, second quarterly, third quarterly, to where I need to schedule my annual. And first I need to calculate out what day 366 is. So if my admission ARD was April 14th of last year, and I count out 366 days, that tells me that I can't schedule my annual ARD beyond 4/15. So April 15th is the last day, is day 366. But I also have to be within 92 days of my prior quarterly. So my last quarterly was on the January 10th. And so 92 days from January 10th is April 12th. So now I have to look at both of those dates together and say, okay, I cannot exceed the earlier of either of these dates. So my annual ARD has to be 4/12 or earlier in order to remain in compliance with both within 366 days of the prior comprehensive and within 92 days of the prior quarterly. So a lot going on there. And then we throw in a sig change. So the significant change in status assessment. Now this one has a very different ARD rule. The ARD must be set and the assessment must be completed, which includes the MDS and cause, within 14 days of the determination that a significant change has occurred. Now, when we talk about significant changes in ARDs, I know this could be an entire separate presentation just talking about sig changes. But what I really want to emphasize here is, number one, in chapter 2 of the REI User's Manual, it provides really great definition of significant change, what the criteria is, examples of when a significant change in criteria is met for both improvement and decline, and other special situations such as hospice. And what you will gather from that reading in chapter 2 of the REI User's Manual is that ARD has to be set within 14 days of the determination that a significant change has occurred. And when you start to watch a resident for a significant change, you also have time from when that change started to make that determination. So we're going to be watching residents for up to 2 weeks to see if they've had a change. And then once we've determined that a change has occurred, we have an additional 14 days to schedule that assessment and complete that assessment. So I'm just going to use a really simple example. And I'm just going to use a fictional resident I'm going to call Rosie. And Rosie was a resident that could independently ambulate through the facility. She was very independent with a lot of cares, and she developed pneumonia. And for the last few days, she has been mostly in her room in bed and requiring staff to help her to the bathroom and to help her eat her meals. And so pneumonia could be self-limiting, which means if we wait a couple of days, Rosie could recover and return to her baseline before the end of this 14-day period where we can just monitor the resident. However, Rosie continues to decline. Now she's had a weight loss. She's needing more help with ADLs. She's no longer getting up to the bathroom. And so maybe we're out to day 7, day 8, and we say, okay, Rosie is not going to rebound back to her baseline within our 14-day observation window. So now we're going to determine that a significant change is required. And that needs to be documented in the medical record. That shows a very clear connection to your facility's process. So you've documented that you're monitoring Rosie for her decline to determine if a significant change criteria has been met, which has not been met at this time. And once your team determines that this criteria is met, document that determination, because that shows clearly in your medical record your facility's process, how you critically thought through this resident's changing condition, and when you determine that significant change was needed. From that determination, you have 14 days to set the ARD and have that MDS and cause completed. Now, I do want to reiterate one thing is that there are some events that are so big that it really is the determination in and of itself. And there's no real thought process that needs to go through that. One such example is, say, hospice election. The RAI manual tells us that with hospice election, that automatically meets the criteria of a significant change. So if a resident elects hospice, that is the determination date, and you have 14 days from that determination to set the ARD and complete the assessment. Another such example would be, let's say a different example with Rosie. She was up independently ambulating. She fell and fractured her hip, was out to the hospital for a repair of that hip. She comes back. She needs a lot more assist. She needs therapy. A lot of changes have occurred, definitely more than 2. And that change, when you noted it on admission, would be enough to say, oh, yes, a significant change has occurred, and you need to schedule that within 14 days of her return to the facility. So there's some really big items that really stand apart from the gradual slow changes that you may see in your long-term care residents over time. But the key is ARD set within 14 days of that determination. All right, so let's see how this SIG change impacts that standard OBRA assessment cycle. So this is like really like, hey, I have my regularly scheduled program. I'm just cruising around here, comprehensive, first quarterly, second quarterly. It's just a cycle that keeps going. And then I have, bam, a significant change. And it really is like throwing a wrench into something that's just would normally just keep on moving. The significant change in status assessment is a comprehensive assessment, which means it stops the cycle where it's at. No matter where it occurs during this OBRA cycle, it stops it and it resets it back to that comprehensive point. So that comprehensive assessment always starts that cycle, because the comprehensive is what is going to guide when the next comprehensive is due 366 days later, and then next quarterly within 92 days. So next quarterly, 92 days after that significant change, and the next comprehensive 366 days from that prior from that significant change. So if you consider the standard assessment cycle like a clock, where that's always starts with a comprehensive assessment, whenever you have a significant change, that resets it to that beginning point at the top of the clock with a comprehensive assessment. All right, and then we have another assessment that can cause so much confusion, and that's the significant correction to prior comprehensive. Now, the significant correction to prior comprehensive is typically, I'm going to say, more on the rare side. It's not one of the assessments that we use on a routine or common basis. We only use the significant correction when we've determined that a significant error has occurred on this assessment. When we talk about significant error, there is, again, in chapter 2 of the REI User's Manual, really great definition, some great examples. But how I really like to explain the significant error is that this assessment or part of this assessment does not correctly represent the resident's clinical status, and it cannot be corrected with just a modification. So for example, if I coded section M as a resident had no wounds, but they actually had several wounds and several treatments, which resulted in a care area assessment not being triggered, which resulted in a care plan not being developed, that goes way beyond just a simple modification of a item on the MDS. It had a lot of impact on this overall assessment. So in that case, I may determine that this is a significant error and I need to schedule a significant correction. If the significant error was found on a comprehensive assessment, then the corrective action is the significant correction to that prior comprehensive. This is not the same as a modification. This is a brand new assessment that I'm completing on that resident with a new ARD, a new look back period. It's a brand new assessment that I'm going to collect the correct information on to have a clinical assessment that accurately represents this resident status. So this is something that does not happen very often. Most of the errors that occur in the facility can be corrected with that modification process or the attestation process. But if you have, inactivation process. But if you have an error that goes beyond something that can be modified and easily corrected, then that's when you need this. Now, a significant correction prior comprehensive, because it is a new comprehensive assessment, has the same impact on the OBRA assessment cycle as the significant change in status assessment. So it will reset that standard assessment cycle clock. Okay, and very similarly, OBRA significant correction to prior quarterly. This is again where you found that you had a significant error. And again, I think I forgot to mention this, but it was on the prior slide. From the date you determined or you found that significant error on that assessment, you have 14 days to complete the significant correction to prior assessment or to the prior quarterly or prior comprehensive. So if you found that significant error on a prior quarterly, which again had not been corrected with a subsequent assessment, then you would need to schedule this significant correction to prior quarterly. And it has the same impact as another quarterly would have on the assessment cycle. So from the ARD of this significant correction of a prior quarterly, your next OBRA assessment would be due within 92 days. Whew, that was a lot of information, but I want to spend a lot more time on some of our later slides. So you have all that information in the slides for your reference. All right, so let's move on to the PPS assessments. And if you're not familiar with the term PPS, this is prospective payment system. This essentially means that these are Medicare. So this is a Medicare within the skilled nursing facility, the PPS assessments. Just like with our OBRA assessments, we also have this great chart in the REI User's Manual. This one's on page 2-45 for the PPS assessments. I know it's really small on this slide, but the REI Manual is available online. You can print this out, flag it in your paper manual, whichever works best for you. All right, so when we talk about Medicare scheduling, this has gotten substantially easier since 2019 and when we went to the patient-driven payment model. So for Medicare, we have one scheduled assessment, and this is your 5-day PPS assessment. And this assessment has an ARD window that has to be set within days 1 through 8 of the Medicare Part A stay. And this is an assessment that will pay for the entire Medicare Part A stay unless an interim payment assessment or IPA is completed. And then the completion date is within 14 days of the ARD. So when we talk about the Medicare assessments, it's a little bit of a different concept because we have a very, very strict deadline here. So we have a day 1 through 8 in which we can schedule the ARD. And then I like to kind of pretend that there's a wall that ends at midnight on day 8, or so up till 11:59 on day 8. Anything that happens before that wall, that strict time frame, whenever you're within day 1 through 8, you can really adjust and move this ARD. You have a lot of flexibility with this 5-day ARD. So when I'm physically within those days of days 1 through 8 through that Medicare stay, I can move my ARD to day 3. I can move it out to day 6, out to day 8, back to day 6. I can move it around as much as I want, as long as I'm within days 1 through 8. You want to be cautious though, because you do have to think about the items that have to be completed on that 5 days. So you have resident interviews, which of course, once you have that ARD, you want to communicate that to your team. So the PHQ-9, the BIMS assessment can be completed to be captured on that assessment. Once I get on the other side of that wall, so that green line is my wall. When I'm on the other side of that wall, I can no longer go back in and adjust my ARD. So if I had set my ARD for my 5-day on day 6, and now I'm going through the chart on day 10, and I think, oh man, if I would have used day 7, I could have captured these other items. You can't go back and change it. That date is set. I'm already outside the ARD window. What was set is set, and I can't move it. Now, in addition to that, if I'm sitting out there, say I'm on day 10, and I realize that I never set a 5-day, there's not one that exists in the system, then now I can't go back in time past that wall to schedule that assessment. And the rule is that the earliest I can set that missed ARD is the day I realized it was omitted. So I'm sitting here on day 10, I realized I did not schedule a 5-day. I can open that 5-day for day 10. So day 10 would be my ARD. It would be 2 days late, 2 days out of compliance, and I would result in 2 days of default payment. But then I am able to bill that HIPS code from that 5-day for the rest of that Medicare stay. And again, that's only true if the resident is still on Medicare and in my facility as of day 10. All right, so ARD setting for your 5-day, very important to pay attention to, especially with that first day 1 through day 8. And just to reinforce this is your Medicare Part A stay days. So a lot of times this will correlate with admission. The resident admits on Medicare, but there's also times that this occurs in the middle of a long-term care stay. The resident might have been Medicare, came off to a non-skilled level, and then was picked back up on Medicare during their 30-day window. And the day we pick them back up would be day 1 of that new Medicare Part A stay. This could also occur right now, since we have that 3-day hospital stay waiver, where if a resident met all the other criteria and was able to apply the 3-day qualifying hospital stay waiver, then we might have a Medicare stay that starts without being discharged and reentry to the facility. So it would stand on its own, with just the Medicare stay need to be counted separately from anything else. All right, so we also have the interim payment assessment, and the ARD rules with this is really simple. It's optional. You can set it where you want to set it as a facility. Now you do want to be able to set it so that you can complete a section GG, as well as the resident interviews, which are key for the determination of the patient-driven payment model HIPS codes. But there's no late, there's no early, there's no regulation of this ARD. It is optional and up to the facility discretion when and whether they will complete the IPA assessment. The last assessment we have is the Part A PPS discharge. And we haven't talked a lot about discharge assessments because they're really driven by that event date. So for your OBRA discharge assessments, those have to be on the discharge date. But with the PPS Part A discharge, there's a little bit different rule here. And that is that the PPS Part A discharge must equal the date of the end of the stay, so A2400C, or it can equal the date of the physical discharge if that date occurred on the day or the day after the end of the Medicare stay. And then we can combine it with that OBRA discharge assessment. And I have another slide here that really says the same thing. It shows a little bit more of what's on the MDS. And then also, again, if A2400C is on the day of or the day before the physical discharge, then we can combine the OBRA and PPS discharge, but we have to use the ARD of the physical discharge date. So I have a couple of visuals here. This first one is we have a last day of Medicare and the resident remains in the facility. So this could be a last day of Medicare because they exhausted, because we issued the NOMNIC or the generic notice that took them off of skilled coverage. So this is the last day we billed to Medicare. This is also the date that'd be equal to A2400C. So the Medicare end date. The PPS discharge ARD would be on this date. Now, if the resident has a physical discharge, which is on the day of or the day after that last day billed to Medicare, then we can combine the OBRA discharge and the PPS discharge, but we have to use the date of the physical discharge. So very similar, but slightly different circumstances here. And this is when we can combine that OBRA and PPS discharge assessments. And as we're talking about combining our OBRA and Medicare assessments, I did want to talk about this briefly because you can combine these assessments, and there's a lot of reasons where we would want to combine the assessments. And there's also a lot of situations where it might be better for the facility to use separate assessments. And it really all just determines on the unique situation for the resident and what services and cares need to be captured on each type of assessment. So one of the assessment combinations that we frequently have is the admission with the 5-day assessment. So here I have the admission ARD window, which is day 1 through 14. And then I overlapped it with the 5-day ARD window. And as you can see, the days in green are the only days that overlap for both assessment types. So whenever we're combining two assessment types, we have to meet the criteria of both assessments. And if we don't meet the criteria of both assessments, we cannot schedule those together. So here we have day 1 through 8, which would be the ARD window for a combined admission 5-day. Now, there's another thing to consider when you combine the assessments is you have to be in compliance with all of the rules. So we also have to be in compliance with completion date. When we talk about completion of a standalone 5-day assessment, you have ARD plus 14 calendar days. But when we talk about completion date of your admission assessment, you have to have it completed within 14 calendar days of their entry into the facility. So if you have a combined 5-day admission assessment, you have that ARD set within days 1 through 8, regardless of where it's set there, then the assessment must be completed by day 14 because that's the more strict of the two criteria for either assessment. All right. So we've gotten through all of the OBRA and all of the PPS assessments, and now we're going to talk strategy. The first strategy is to know all the rules. So we have to be in compliance with all the rules because when we don't follow the ARD scheduling rules, that can result in payment penalty, both on the state side and on the federal side. So be familiar with your state requirements, talk to your state REI coordinator or their contacts within your state so you know if there's anything above and beyond the federal regulations that your state requires. And I've worked with a lot of different states, and there are some very unique nuances between different states. So especially if you're newer to the job and you're not familiar with any, sometimes the only way we learn those is by a trial and error. We mess up and we learn from that mistake and we move forward. So if you can open that line of communication early to know any of your state requirements, that can really help you get ahead of the game. The REI User's Manual is very much in line with the regulations and notes the regulations throughout the manual. So when it talks about the requirements for the ARD and the completion dates, a lot of that items is the same items in the regulations that the surveyors will be looking for. And you can receive tags on late or missed assessments or even missed significant change assessments. So there's a lot of tags related to the MDS process and the management of the process that are really important when it comes to compliance and survey and regulation. All right, so I'm just gonna try to make this really simple here. So we have an ARD and I use today's date. And with that ARD, and for most assessments, you have, or for most items on the MDS assessment, you have items you're capturing in that 7-day look back window. Now, when we talk about this window, you know, there's other items that have a 14-day look back window. So it's important to know what you want to capture and what the look back period is, and when day 92 is. So for a majority of the things on the MDS, you have the 7-day look back window, and that's why I highlighted that here. However, if day 92 is also April 28th, so I'm setting my ARD on the very last day I could possibly set it, that only gives me that 7 days. I have no wiggle room. I have nowhere else to go, because once I get there, I can't go back in time, because then I can't complete the resident interviews. I can't do the other assessments that are needed to support the MDS coding. So I always need to be starting at the beginning of the month, or I like to start at least 30 days, if not earlier, ahead of when that assessment is due, to really start monitoring for that resident. And one of the questions I always asked my MDS coordinators or nurse assessment coordinators was, what do you plan to capture? And this is a very open question, and there's a lot of correct answers. And we're going to talk about the different reasons we're going to move assessment reference dates. But the one thing that I never want to hear is, I don't know, because that shows that there was no strategy, no thought. I just picked a random day on the calendar for absolute no reason. So I always want there to be a reason, and it can be a big reason, or it can be a very small reason, or it can be a reason that's not, that's more for the NACs workflow. And we're going to talk about that too. But the other thing that we need to know for each resident is, what is their payer source and what payment model do they use? So if you have private pay residents in your facility that use a flat rate, so regardless of what you capture on the MDS, it's not going to change their billing codes, then we don't need to do strict management to look at what we're capturing for that resident. For that resident, we still have to monitor for a significant change and any other clinical changes that would warrant that clinical monitoring, but we don't need to monitor very closely for ARD selection. If we are working in a state that uses case mix for Medicaid, then that is another area that you want to monitor very closely, because whether you're using one of the legacy RUGS models, RUGS 3, RUGS 4, 34 grouper, 44 grouper, whatever grouper you're using, you need to be very familiar with that payment model. If you're not a case mix state, you need to understand what impacts your Medicaid rate for the non-case mix states. So there's always something to be monitoring and mindful of, regardless of your state, but knowing your payment model is really key for that process. And then for your Medicare residents, it's the patient-driven payment model, which is the primary payment system, or the payment model for Medicare right now. And we're going to talk about a little bit, just touch on a little bit. There's so much to the patient-driven payment model that we're really looking at overall accuracy of the assessment, because there's so many different areas across the entire MDS that are used to impact that payment. We want to develop a tracking system, and this can really look however you want it to look. When I talk about a tracking system, I really like Excel sheets, but not everybody likes Excel. Sometimes with Excel, it's more trouble than what it's worth. Other people like just a paper document that they can jot notes on. I've seen people that just use a whiteboard. However you want to track upcoming assessments and who needs to monitor and what the key items that you're monitoring are, you need to have that in your facility. And it needs to be something that fits easily into your flow process, because if it's a lot of extra work, it's probably something that you're not going to keep up on. So develop a tracking system to identify what you plan to capture. You should have a thought process for each resident of, this is what I want to capture, as well as being aware of what other items impact reimbursement. If you're a facility that works in a case mix state that uses a RUGS payment model, you know that this is a hierarchical approach to case mix. So if you have, say, oxygen for that resident, you fall at clinically complex level. So you need to know, am I still planning to capture oxygen? And then knowing what clinical items would actually put the resident up and above that oxygen level clinically complex, and what items are below what you could capture that you don't need to focus on. So you can really aim your focus based on the methodology that's included in those payment models. But above and beyond that, we also have to be continuously monitoring for those significant change in status assessments. And when a significant change criteria has been met, or a resident who we're starting to monitor for because they've had some change, but we have not yet determined if it met the criteria. And utilize those meetings. So we know that there's a lot of meetings. We know that the NACs are involved in a lot of meetings. This is not a list of meetings that I think you should be at. This is just a list of common meetings that occur in the facility. So whichever of these meetings you are involved in at any level, whether you just attend, whether you attend sometimes, whenever you attend any meeting that you find value in, that should be where you really gather your information. So we're at Daily Stand Up and we hear about new admissions. We're hearing about payer types. We're hearing about maybe some of the clinical items going on with new residents. We might find out about a new behavior from the night before or a fall. These are all things that we should be taking a mental note on and a physical note on to say, okay, Jessie fell. Let's watch to see what's changing, what's going on with the screen. Did they refer to therapy? Really start watching, how that care evolves from that event. A resident had a severe behavior the night before. What triggered it? What's going on? Is there other interventions that are being put in place? And many of these are going to resolve and the resident's going to return to their baseline, and a significant change may not be indicated. But it's that process and using all of these meetings that you already are attending to your benefit so that you can really keep your eyes and ears open to what's going on in your facility. Now, if you have a very large facility where it is very difficult to track such a large population, then that's nice if you have other MDS team members where you can really divvy up wings or groups to help keep the eyes and really share the workload of this key process to monitor those changes. Here's my little information on PDPM. There's so many services and conditions that impact PDPM because it has the PT component, the OT component, the speech component, the nursing component, the non-therapy ancillary component. And diagnoses plays a really key role in many of these components, the comorbidities, the resident's function with section GG, and then services, treatments, wounds. There's so many things that impact this, and it all comes down to that documentation of the services, the treatments, the wounds, and a lot of times the diagnoses fall on the NAC side. So making sure we're just giving a lot of attention to those diagnoses, making sure we have the documentation from this physician to support them, making sure we've dug through that record to ensure the diagnoses that the resident has are captured on the MDS appropriately. And this is where I really say the PDPM payment model requires intense monitoring and research at the beginning of the Medicare stay. Again, we only have through day 8 to set that ARD. So we have a lot of intense time spent during those first 8 days to make sure we have all of these systems and processes, documentation in place. This is where the NAC can be out talking to the nurses, saying, hey, I read this wound note. It's not clear what type of wound it is. I need you to do some follow-up with a physician so we can clarify that. So there's a lot of things that might need to be done very early in that Medicare stay because we have such a tight time frame in order to capture those services on the MDS. And then we're going to shift to our ARD selection for case mix. And I mentioned it before. I always ask the question, what are you trying to capture? Why did you set this ARD on this date? And it can be for so many different reasons. So it could be that you have a resident that receives a blood transfusion every 4 weeks. And so you know that you want to capture that blood transfusion every 4 weeks. And if you're a case mix state, then you know that this resident's going to fall into a certain level. So then you're only looking at any of those services that would be above that in order to capture. You also might have a resident that has a tracheostomy, and that's something that they fall into that high extensive care level assessment after assessment. There's no extra work that you need to do. So unless the resident were to also get a ventilator, then that's likely the only category that they're going to be able to capture. And then you can schedule that assessment really anytime that you want to. But knowing your case mix methodology is really key. One of the examples I like to use is oxygen because it falls right in the middle there at clinically complex. And so if you have a resident that's receiving oxygen, and they also have recently started a restorative program. The restorative program is great. I'm a huge advocate of restorative programs. They are such a benefit to the resident. But if the resident achieves a clinically complex category for a case mix state, then that restorative is only used as an in-split for your reduced physical function, your behavior categories. Once you get up to clinically complex, then the PHQ-9 score is used for the depression in-split. So even though the restorative is important and is really key on this resident, we want to capture that and use it on in the care plan and make sure it's care plan appropriately. It's not necessary for us to adjust the ARD to capture 6 days of restorative on that assessment when the resident's going to achieve a case mix group that is higher than that. And I apologize if you're not in a case mix state, that might sound like a really weird concept, but if you work in a case mix state, then you probably understand that you have to be strategic with your ARD selection because there's things that you don't need to capture in some cases, and other times you'll want to capture that exact service. So it's really knowing in that hierarchical approach of how the RUG system is used for many of those case mix states to capture what you want to capture. But the other thing that is really important, especially for the nurse assessment coordinator, is to monitor your schedule and making sure you have an adequate time to complete the assessments. So if you look ahead at your schedule and you say, oh my gosh, I have 6 comprehensive assessments the last week of the month, and I also have to do all my end of month stuff, that's a huge workload for that week. So now you can look at those 6 comprehensives and you can say, okay, well, I can schedule a couple of them throughout, or, earlier throughout the month so I can ease that workload. There's nothing that says we have to have those as close as we can to day 366, unless you have more strict state rules. The REI, the federal regulations is you can set it as early as you want. But the key here is that you have that flexibility. So you might say, I might ask you, why did you select that ARD? Well, I had 6 comprehensives due that last week of the month, so I spread them out. This resident's on oxygen, we're still going to capture it. This resident just started therapy, we can capture it anytime within the next 4 weeks. So I set it here. So whatever you're trying to capture, as long as you are not sacrificing what you want to capture, so that assessment accurately represents the cares and services your facility is providing, then you have that flexibility to move it. You can also adjust assessments for vacation. Again, work-life balance is key for everybody, and including the nurse assessment coordinator. I know sometimes it is so hard to get even a day off without a phone call. So being able to really lighten the workload during a vacation can help to peace of mind and ease that you know that there's not an overwhelming assessment or anything due while you're out. All right, so now we have climbed on top of the mountain and we're going to stay on top of the process. And so the first thing we want to do is educate. When we have a team where we can send out the ARDs and the entire team can see the assessment reference date that we set and know when the assessment needs to be completed, when their supporting documentation needs to be completed, when their interviews need to be completed, that really helps that entire process. So we need a standard method of communicating the assessment reference dates and the completion dates. We also need to have a process to monitor and communicate changes that come up that are unexpected. You might be completing an assessment and something happens and you need to adjust an assessment, and your team needs to be able to flow with you to make that change. And we also need to ensure that all the people that are responsible for coding the MDS are competent in the areas that they need to code. And we can't make any assumptions. You might be new to the job, but we don't want to assume that just because someone has been coding the MDS, say in the dietary department for the last year, that they were adequately trained. So it is important to monitor the work, to be involved in those audits and provide education as needed. And if you don't feel that you are appropriate to complete that education, talk to your leadership, because there is a lot of education opportunities out there, and opportunities to have somebody come in and complete that training that's needed for the accurate coding. The ARD could really be the center of a lot of communication. As I mentioned earlier, the ARD drives the look back periods when the supporting documentation and assessments need to be completed, when the resident interviews need to be completed. Also, when we know then that we cannot complete the connotes before the ARD, because we want to collect all that MDS information as up till midnight of the ARD before we complete the connotes. So it all really meshes together around that ARD. When you are setting your ARD and your planning, looking ahead is really the best advice I can get to if you can get beyond looking at what's due today and tomorrow. And I know sometimes, especially in a lot of the situations that facilities have been in the last 2.5 years, when you're ready and you're able to get back to a more of a normal flow, normal situation, and your facility may not be in crisis mode anymore, then that's when we want to start looking at projections and looking ahead. So we're looking at assessments that are coming due in the next 20, 30, or even 40 days. And we're projecting what we expect to capture on that assessment. Knowing your payment model is really key for this. And when you get to the point where you can project and you can say, okay, the resident has these key clinical items, so I expect them to be in this payment group or payment category, case mix group, that can really help you to say, okay, this is what I'm looking for, and this is what changes could happen that I would need to adjust that ARD. When you also plan ahead, that gives you more flexibility. So you can say, okay, I have a really heavy caseload at the end of the month, and you have more time to really spread those assessments over the time frame. Utilize your meetings. There's a lot of meetings that are happening. We don't want another meeting just to collect this information. So as much as you can, utilize that information, but also get out there and talk to the resident. If the only time you're able to get in and visit the resident is when you're doing that resident interview, use that opportunity to your full potential. Observe the room, observe if the resident has shortness of breath, ask questions that are beyond those scripted interviews, so that you're really feeling and seeing and getting a full picture of that resident during that time frame. And then again, tracking, any type of tracking that fits into your workflow is going to benefit you. If it does not fit into your workflow, it's going to become an extra task that will get left behind. So develop something that you think will really work with what you do every day already. All right, and with that, I believe we have time for questions. And I think if you guys want to chat your questions, you can drop them into the chat. And I'm just looking here. And I do not know what the Wyoming payment model is. I apologize, I'm not familiar with Wyoming. All right, another question we have is, can you please describe about how many quarterlies are acceptable? Is an early quarterly needed to capture case mix? And that's a great question. Depending on your state. So in one of the states I used to work with, we had a window of time which we could set our quarterlies, and they provided that window for us. But many other states just follow the rules in the REI, within 92 days. And so there could be opportunities where you have changes in your resident that you want to capture, but they're not changes that are big enough to warrant a significant change in status assessment. So in that case, you could have early quarterly assessments, and you could result having 4, maybe even 5 quarterly assessments. Just always make sure you keep track of that annual assessment and when it's due, so that you're what I don't want to see is that you're doing a quarterly assessment and then 2 weeks later doing an annual, because what would have probably been the better option is to just move that annual up to do an annual rather than like a 4th or 5th quarterly. So really depends on the situation and the timing of those assessments, but it's one of those processes where you have that freedom to schedule those quarterlies. But again, you only want to do it when necessary, because any additional assessment is, again, additional work. Okay, I'm looking to see if there's any other questions. I do not see any more questions in the chat.
Jessie, thank you. That was phenomenal. That's a lot of technical information and a lot of work. I just want to reiterate that the recording of this presentation will be available on the Mountain Pacific website. Give us about a week to get that posted. And then we will also send out the slides from this, the PowerPoint slides that Jessie used, and the recording to the recipients who attended this presentation, so long as we have your email and the registration link, which we should have. Just one more comment, and that is that Mountain Pacific will be hosting another MDS training. This one will be very basic information for new MDS coordinators, or those new to that language and new to that role. We will be offering that on May 26th at 2 o'clock Mountain Time, so you might placehold that on your calendar. And again, thank you to the Wyoming Department of Health for sponsoring this presentation. Any last minute comments or questions before we conclude? It'd be great if you would fill out the evaluation link. That helps us to guide our next presentations and improve our practices. So thank you so much again for joining. Thank you, Jessie and Tim.
Thank you. Thank you, Jill and Tim. And thank you all for joining.